Hi, I am Dina Amin, an assistant professor of surgery from Emory University, and I'm so excited to share my talk to you about one of my favorite topics in surgery. I don't have any financial relationship to disclose. As we all know, trauma could be a simple, straightforward case that you enjoy during the operative time, or it could be a complicated and a surgical nightmare. In the coming 60 minutes, I will convince you to use computer-assisted surgical planning and computer-assisted navigation in your trauma practice. So this is a perfect example of post-traumatic deformity. A 50-year-old female patient with a history of MVC resulted in multiple facial fractures treated by a community surgeon, been referred to me, and her chief complaint is, "This is not me. Can you fix me?" Analyzing the patient's picture or clinical exam with the imaging resulted showing that the patient has enophthalmos. And that's mainly because increase of her orbital volume. She has facial asymmetry, a cannula significant facial asymmetry. And that's because of inadequate zygomatic-maxillary complex reduction, which shows here that the surgeon was unable to reduce the zygoma in anteroposterior and a vertical dimension. Patient has traumatic telecanthus, which compounded the facial asymmetry, and that's because failure to reduce and to fixate the NOE fracture.